All right, so Airway 2 lecture continued. It was getting kind of long in a way. It'd probably hard to sit through a couple hours of video and not be engaged in the classroom. So here we are with Airway lecture 2, part 2. Share the screen. We're back at it. All right, so basically what we've learned so far about airway management is that in the EMS world, the most of the intubations you're going to go get are not going to be OR perfect. They're going to be very messed up. They're going to be full of food, and they're going to be pretty damaged and traumatized, and it's not going to be wonderful. So how do we get around that? Well, we need to make a plan. We need to make a plan. So how do we do that? Well, we look at anatomic findings. My first look in the airway is to see congenital abnormalities. What does it mean for something to be congenital abnormality? What do you think there, Houston? Nope. You're not here? All right. Hi. Riverdale for life. Riverdale for 8 months.
You want to try to find those moments when there's normal person, you can identify a little bit.
Very good. So we learn how to recognize a pattern break. So everything we learn what normal looks like, and when something's not normal, we can see that. How about a recent surgery, trauma, infection, neoplastic diseases? These things can be predictors of the difficult airway. And then we learn of the lemon pneumonic. There's several of them out there. There's the heaven pneumonic, and then the one I teach is lemon, because it just seemed the simplest, and y'all a bunch of hose dragging firemen, so simple is best. So the lemon law. L stands for look externally. Before you intubate, look at their body outside. They got a big old fat neck. They got a bullfrog neck. They got turkey arms. They got lunch lady arms or hay fat. Like if they was to wave with their fat wave too. Yeah, I tell you what, I bet they can cook. But watch out for them. So look externally. Next, we have E, evaluate the 3-3-2 principle, which I'll get into more later. Mallampati score, which is an evaluation of the inner structures of their airway. Is there any kind of obstruction, and what is their neck mobility? What is their neck mobility? So check it out. There's your lemon. Yeah, yes. All of these things can help you predict a difficult airway. You're right. So the lemon pneumonic, let's take a look at it. So look externally. So we're looking for facial trauma, large incisors. What do I mean by large incisors? Wrath.
Large incisors?
Yeah. There you go, big teeth. Buck teeth like Bugs Bunny. So large incisors. How about a beard? Beard's going to affect us how? Seal. How about a large tongue? That could get in the way. Now, evaluating the 3-3-2 rule. Incisor distance. So, are they at least 3 finger breaths wide? Can you fit 3 fingers in their mouth when it's open like this? The hyoid mental distance. So, can you fit 3 fingers underneath their chin like this? And the thyroid to mouth distance. Can you fit 2 fingers in that space? Are they at least a Mallampati 3 and under? And I'll show you what that means more in detail in a minute. Now, obstruction, presence of any condition like epiglottitis, peritonsillar abscess, or trauma. Then we check their neck mobility. How do I check it? You move the head around, head tilt, chin lift, and check it out. Y'all ready to move on? Y'all need time to make notes. No reply. We click on. So let's go ahead and look externally. We already talked about looking for short, thick necks, morbid obesity, dental conditions. That one looks pretty easy. Look externally. What about evaluate 3-3-2? I figured you would need a picture for that, right? All right, here you go. So mouth width is more than 3 fingers is best. Mandible length is 3 fingers is best. And 2, the distance from the hyoid bone to the thyroid notch should be at least 2. If that is all lining up, they're going to be an easier airway. If not, they'll be more difficult. What about old Shamu neck? Old bull neck? That's going to be a difficult intubation. Why? Shorter, fatter neck, probably a more anterior trachea. which means it's going to be farther to the front and harder to see, even if you lean that head all the way back. What mnemonic did they teach y'all up there in Ohio?
I think they got us a mnemonic for that. You said or remember all the factors.
All right, so here's the truth. I use the mnemonic, but also I kind of just look around, see if there's any kind of weird stuff. You can keep it simple. Registry likes lemon, and lemon makes it easier on some of y'all that are more analytical and need some kind of system to follow. Some of you are like that. Some of you more like me, like I'm just gonna look in there and it looks all right. Let's dig around. Let's put the hook tube in the hole. There you go. So what is Malampati? Everybody ready? Malampati. It notes oropharyngeal structures that are visible in an upright seated position. So class 1, you can see every little bit of thing. Class 2, you see it narrows. Class 3, narrows more. And then class 4, you can't even see the uvula. Can't even see the uvula. So you've seen a couple of airways now, right? You want to see the real Malampati? You ready? So if Malampati is helping us predict a difficult airway, you got Malampati 1, 2, 3, 4. You want to try and intubate 4? What is your success rate on that?
Open a prayer.
Drive fast, bag them, iGel maybe, crike them, something. Malampati 4 is going to be a very, very, very difficult airway to predict.
Digital.
You can try it. You know, digital I reserved mainly for when I had no other choice. This is going to be better than digital because digital is still very blind. You're feeling around, and with that, am I really feeling the epiglottis? Am I really like? Am I really where I want to be, or is this like somebody's leg fat? Nobody. Yeah. No, they didn't. You can give it a shot, but you'd still be blindly kind of digging around. At least with this guy, you can lift and move tissue. It's got a light on it. You can see things. And the newer King Visions, again, they're video scopes. They can record. They can Bluetooth. They can send the video feed to the OR, the ER, excuse me.
Change out your batteries on 3 of them of the video camera, whatnot.
What? They work now?
Yeah, I got 3 of them. There might be 2 that work.
Thank
and
you.
1 that's broke, or 3 that work and 1 that's broke.
That's hot.
And then change out the batteries.
That's useful. Y'all about to be using them. So that was good. Good you do that then, because we'd probably end up doing it the day of. All right, obstruction. There's crap in the way. Foreign bodies, obesity. Can your own neck fat be in the way? Yes. You ever try to put on some pants that you used to wear that you can't wear now, but you're trying to wear them anyway? Can your own fat be in the way? Yes. Yes, it can. Hematoma. What's that there? Cobb.
There's a bruise.
All right, a bruise.
Sometimes can be called bone bruise. Channeling very deep.
Yeah. And there could be masses down there. Now, neck mobility be our last one. Sniffing position is ideal. Oh, excuse me. Sniffing position is ideal. Why is that? Make sure everything lines up. Make sure that you have the utmost clearance and utmost visualization of the airway. So neck mobility. Can you put that head all the way back and expose that glottis? Possible. Depends on, again, how mobile their neck is. You know, a lot of that there. Neck mobility might be a problem with trauma patients. Why do you think that? JBD could be a thing, but why with trauma patients? What do you think there, Houston?
I think trauma patients would be a problem just because of the actual physical damage that it does to the neck.
What else are you doing in trauma patients?
I'm trying to make sure they don't bleed out like the most important.
You're holding C-spine.
Oh, yeah.
If you don't know what's happened or how they've gotten to this traumatic arrest or whatever, you're going to board them, aren't you? You got to get them out of the car, and I'm pretty sure one of y'all has put a collar on, hopefully correctly. I hope you know how to intubate with the collar on. That's okay. I'll teach you. We're going to practice that. We're going to put those mannequins in all kinds of weird positions to make you intubate them. Hell, we put that floating floor in there. We put one of them mannequins underneath the floor and made you intubate under there last year. Which, I mean, for some of y'all, it wouldn't be a problem. Like a whole jungle gym down there for you. These ceilings are so tall. So much room for activities. So, endotracheal intubation. We're here finally. ET tube passes through the glottic opening and it is sealed with a cuff that is inflated against the tracheal wall. So, the cuff is inflated and it seals. What is it protecting against? Aspiration. It is securing a patent airway. It guarantees that no matter what goes on from here on out and above, I have got a secure airway. It can recruit all the lungs alveoli. I can get full chest expansion. This is the go-to. This is the coup de grace. Now, there is a danger about putting too much air in the cuff. What's going to happen if you put too much air in the cuff of your endotracheal tube? What do you think?
Pop it.
Pop it? What else?
Put direct pressure on the jugular and pop it off those parts of the head.
I don't know about that one. I think it's kind of far from the jugular.
You know what I'm telling you, that if you inflate it too much, it puts pressure between the skin and circulation.
It could a little, but the main thing I was talking about is the mucosa necrosis. You can put enough air into that bowl, it'll squish the tracheal mucosa and it'll cut blood flow off to it. So you could have necrotic trachea tissue. That's why every bulb is inflated how much? 10 mLs, 10 cc's. Every time, for every patient. So, orotracheal intubation. Through the mouth. Nasotracheal intubation. You guessed it, through the nose. Now, what about endotracheal intubation is good? What about it's bad? Let's talk about it. It's a secure airway, protects against aspiration. It's also an alternative route to IVIO. What does that mean, Martin?
There are some medicines you can have
So there's some medications I can give via the ET tube. Right on. What about the ET tube route of administration should I remember? 2.5 to 3 times higher, the dose. Very good. I like it. The disadvantage is it requires special equipment. It's not that special. It's just a laryngoscope blade and a couple of other little things. But also there's a physiological functions are bypassed. What does it mean that we bypass the physiological functions, Hi? Oh, no problem. One of the disadvantages of an ET tube is that it will bypass physiological functions. What does that mean?
Well, you got to breathe for them.
Absolutely. No matter how good I am at being a ventilator, you know who's better? The patient's own brain. It's smarter than me, better than me in every way in regards to this skill. Because it's taking micro measurements off the chemoreceptors, remember? The chemoreceptors are located in the medulla oblongata. They're sensing changes in CSF. For pH changes, the pH drops, they get more acidic, CO2 rises, your body will be stimulated to breathe. It knows exactly how much of a breath you need and how many breaths per minute you need. Way better than me or you making that decision. So we're going to bypass those physiological functions. What are some complications of endotracheal intubation? You ready? Everybody? Ooh. Well, you could cause bleeding. Why? So you kind of, some of y'all just felt the sharpness of this thing right here. If I was to push hard, would it hurt? Think about you digging in somebody's airway. It's very easy for somebody with a non-gentle touch or a fireman's touch to go in there and just dig around and cut things up and damage things. You can cause more harm than good you did. Now, what's the problem if you go in there and cut some things up and there's bleeding now? That blood's gonna go where? Trachea and stomach. Do you want blood in your airway? Hypoxia. Why? You're taking too long to intubate. These prideful medics, these prideful doctors spend 3, 4, 5 minutes digging in the airway. I gotta get it, man. They're gonna think I'm not cool at the ER. I gotta impress old Shirley Ann, that new nurse up there. They don't care about that. You package that patient best you can. You be that patient's medic, their ditch doctor, by getting whatever airway you can. Any port in a storm, preferably an ET tube, but Tracy missed, I missed, Miss Laverne missed, you gonna miss. You gonna get a lot of them. We're gonna train hard, but there's gonna be some that you just can't get. If God wants them, He's gonna take them. You just do the best you can do. So laryngeal swelling. Yes.
If you do this for the patient's sake, you just go back to BVM, because you still need to give them something much. That our what the BVM?
He said both.
I've never hit a woman. Don't push me. So give it a shot. I give myself 2 tries. After the first try, I'll reoxygenate with a BVM. I'll make a different plan. Now, here's the thing. Now, I'm glad you said that now. What is the definition of insanity that most people think is the definition of insanity? Doing the same thing over and over, expect a different result. So let's say you fail that first attempt. Are you going to go back in there with the same blade? Are you going to go back in there with the same tube? You going to go do the exact same thing again and think it's going to be different? Now, the reason a lot of us fail in our intubation is because we don't change the plan. We don't change blade sizes. We don't change blade types. This is a Miller. Go to a Mac. I started with the Mac 3 because that's my favorite. That's my go-to. That's my guy. That's my dude. However, he ain't working on bullfrog neck. So what do I got now? I got Miller 3. Let's try this guy out. And the Miller 3 can sink that putt. Got him. So don't be afraid to change the game. Now, I gave myself 2 tries. If you want to do 3 tries, fine. You pick your number. But don't make it 5 minutes between each time. You dig? That's not patient care. That's idolatry of yourself. That's me wanting to be paragod. So don't go back in there with the same damn plan. Change the blade size. Change the head position. Change the blade type. Try something new. Make a plan. Make a new plan. Have you ever seen a paramedic miss an intubation and then do the same damn thing with the same damn blade? Not changing one thing? You have? They didn't get it the second time either. Why? You did nothing different. That's enough soapbox. I just feel very strongly about it. Because I've seen the same thing. I'm like, oh, not my circus, I guess. You don't want to try this one. Oh, you got it. Yay. I'm helping. I'm helping. So other things we could deal with is laryngeal swelling. Why? You went down there and irritated the tissue. Laryngospasm. You went down and irritated the tissue. Now the larynx is collapsing upon itself. Vocal cord damage. Instead of this smooth baritone, now I got what? This rasp. Only you and your loved ones to prevent mesothelioma. You don't went in there and damage their vocal cords. Mucosal necrosis. Where do I get that from? I mentioned it earlier. Overinflation of the cuff. Barotrauma. These are complications you could run into. The anatomy of the ET tube, pretty basic, man. It's a plastic tube. It's got a proximal end, cuff and a balloon, and a distal tip. Let's take a look. We got Murphy's eye here, which is just an opening there where air flows in and out. Also, if you're using a stylet, which is a kind of a coat hanger looking thing, it's made of plastic, but it's bendy. You can bend it and help move and shape your ET tube how you want because of this harder plastics inside of it. So if you've got a stylet, you can mold the ET tube to how you like it. Remember we said yesterday, the trachea is not a straight tube. So sometimes I would like to put a hockey stick on my ET tube. You find what you like. So Open on Murphy's eye. We got a pilot balloon, a 15mm adapter there for that to fit on. So what is that right there? The 1522 adapter is the end piece that connects
BBM.
BBM. And then we have a 10 ml syringe. Why a 10 ml syringe?
Only inflate the cuff to 10.
Only inflate the cuff to 10. Any more, and we're going to experience what? Possibly cutting off the jugular, possibly mucosal necrosis. I don't want that. I don't want that at all. All right, so these things come in different sizes. So, is it news to you that tubes come in different sizes? It's not news to Chamberlain. Very experienced in tube sizes being different.
Yeah, absolutely.
So they range from about a 2.5 to a 9.0. The pediatric ones can go even smaller, like a size 0. And it looks like a straw at some point, especially the neonatal ones. So the 9 and the 10, that'd be very rare to use. I've actually never had a patient get a 9 or a 10 tube. Most patients, most women are 7.5s. Most men are about an 8. Bigger men, probably 8.5. You just gauge your patient. What's the easiest way to do that? Hold the thing up to their body. How far is it going to go down once it's in their throat? Don't make it complicated. So, how do I know what tube depth I'm going to use? Huh? What's my tube depth? There's a formula. So tube size times 3. So if I have a 7 size tube times 3, that's 21. So I'm going to insert the tube to a depth of 21 centimeters. Why does depth matter? If you go too deep, that tube will veer off to the right lung. It's called a right main stem. If you go too deep, it will only inflate the right lung and not the left lung. Is that good for them? No. But this is also why after an intubation, you check several different things to make sure you've got the intubation and you got it correctly. Like watching the tube pass through the cords, condensation in the tube, listening to breath sounds bilaterally on both sides, listening to gut sounds, making sure there's no gurgles and burgles in there. If you hear gurgles and burgles, you're probably in the esophagus. What else? The esophageal bulb detection device, which is something you put on the end of your ET tube, and it will indicate if you are in the esophagus or not. Then, of course, there's the old tried and true gold standard AHA recommendation of capnography. What is capnography? Me too, coffee, me too. No, it's not your fault. I had a lot of cheese for lunch.
You're asking about technology.
Capnography, what is it measuring there?
CO2.
Thank you. CO2. Now, what is a stylet? Stylet is a semi-rigid wire that's inserted in the ET tube. It can mold and maintain the shape. It should be lubed for removal. You can use it to bend or form a gentle curve. And the end should rest at least a ½ inch from the end of the ET tube. You do not want to push the stylet through Murphy's eye. Remember, Murphy's eye is the hole at the end of the ET tube. I'm going to grab some ET tubes here in a minute so we can play with them.
What's that eye for again?
Air to flow out of it. Which, again, there's a big hole at the bottom, which makes no sense, right? I didn't create the thing. I'm just telling you about it. So it's a ½ inch from the end of the ET tube. That's a great idea. So we talked about this thing having a gentle curve to it. Nothing wrong with a little curve. Hey. So here's your ET tube. It came out of the box like this. Why do you think so? Intubating. So you can hook it into that glottic opening right there. How? You'll always intubate with what? Your left hand is going to be what holds the laryngoscope. Why? See where the light's at? They don't make right-handed ones. You will not be able to see with your right hand. So, left hand holds the laryngoscope. Right hand holds the tube. Now, me personally, I've always got my 10cc syringe always hooked up to this already. It's in my hand. As soon as I finish, I can go ahead and push and got it done and ready to go. After you confirm the tube is in the trachea, do not take your hand off of the tube. It would make me very upset. You know how much it'll make you upset when this thing falls out or some idiot pulls it out? Very. So until you have a commercial tube holder on this thing, keep your hand on it so it doesn't come out, go deeper, go less in there. Make sure it stays on there until you can have that commercial tube holder. Everybody knows what that is, right? The ET tube holder. It just sits there and holds it. It's got a bite block built in. It's got Velcro. It'll hold this thing in place. Now, for cheaper services, you may have to do a chevron. What's that? Take some tape, tape it around here, and then tie it around the back of their neck. It ain't stupid if it works. It's just not, it's not real cash money looking. You dig? Cool. PD patients, they have a funnel-shaped cricoid anatomy. Their cricoid ring is funnel-shaped, which means it narrows to a point. So there's no need for a distal cuff in most cases. When they hit about the age of 8, that'll change. When they hit by the age of 8, that'll change. That funnel shape will start going away. You should not be trying to crike any patient under 12. We learned that the other day, remember? There's a reason that anatomy has not shifted to adult anatomy yet. They're not little adults. They're different humans. They are different humans. Anatomically, they are different. What is the formula for calculating tube size for a PD? Age plus 16 divided by 4. Age plus 16 divided by 4. So a 4-year-old plus 16 is 20. Divided by 4 is what? 5. That is a size 5 tube for that pediatric. How deep we taking it? Well, tube size times 3. 5 times 3 is 15. 15 centimeters down. Oh, look, there are numbers on here. Wow. You can take it there. There are numbers here. Also, there are other information on here. This is a size 9 tube. It's a big one. It's a big one. Ooh. Moving on. Anatomic clues can give you an idea of what you need. Internal diameter of the nostril is a good opening, the size of their little finger. But I would always tell you to have 3 sizes ready. The tube size you think is the right one, the tube size below that, and the tube size above that. Why? What did Goldilocks teach us? This one's too big. This one's too small. This one's just right. You may have to do a little on-scene finagling to make this work. Now, most people fall within the same categories of, again, women 7.5, most men are 8s, except me. I'm a 10. Nobody? Y'all go to hell. So, already have them sizes ready. Now, what about these blades up in here? So, this is old Ironsides. This has been the go-to guy for many a moon. It takes apart. There's a battery in here. Make sure the battery works. Make sure your bulb works. There's a little bulb on the end of this thing. It snaps in place. We got a light that works. The light will be what you need down there. If you don't have a light, you won't see. Believe it or not, it's dark in caves. And when you go into that mouth cave, it's going to be super dark. So you need what? A torch as you navigate the cave. So before your shift starts, you need to do what? You're checking the time. You here all day. Bulbs, blades. What about if these are ones that are supposed to be reusable because they're metal? Make sure they're clean. I don't trust folk. I've come in and had blood on blades. I've come in and there's blood in the ambulance, blood on a stretcher. There's trash all over the place. You can't trust these folks. Clean up after yourself. Decon. After every call, decon. Depending on the level of the call, depends on the level of decon, but every call should be deconned, decontaminated. Your equipment after use should be what? I got this thing soaking in bleach. This is going to somebody else's loved one's mouth. This is not a throwaway one. This was a reusable metal one. If I pick up your mom, Wrath, would you want me to just reuse this thing? You want me to clean it first? Yes? I know it sounds like an obvious question, but I'm trying to get you to buy into this. Clean your crap. Don't go putting somebody else's bloody laryngoscope in somebody else's mouth. So, interchangeable handles, different handle sizes. So, this is called a Miller. Or some people call it the Wisconsin blade. I've never heard anybody around here call it that. So, the Miller is straight. Who this?
Mac.
The Mac. Return of the Mac. Locks in. I like a Mac. This is a Mac 4. It's kind of big. I like the Mac 3. It's just slightly smaller, and I think I can navigate most airways with that. Now, we're going to do this little exercise again to show you what I mean about this blade, because the Mac, a little exercise is not meant to hurt you. It's just meant to kind of show you the difference. That part right there can hurt you. This part is gentle. Think about your patient's delicate, fragile inner throat meat. I don't want to see you cut it. Yeah. So, more likely to damage teeth is the Miller. You'll see why. It's longer. It takes up more space. You're going to be tempted to rock back. You intubate like this. Up, and away. Remember, it's cheers. Cheers. Do not rock back. If you rock back, what's going to happen? You're going to bust teeth. As you insert the blade into the left side of the mouth, roll the tongue out the way. And again, I'll demonstrate this in lab later. You lift up straight. Your wrist is straight. You bend that wrist, you're going to rock back and you're going to break teeth. Do not do it. Mr. Laverne will slap you. Your patient may survive and lawsuit you. Careful. So this thing's actually very useful with infants and children because it is better for difficult airways. And also, they don't really have the teeth structures to mess up. And if they do, they'll grow back because you get 2 sets of teeth at that age. But it is more likely to damage teeth in adults. So just be careful. If you become a Miller person, know its limits and make sure your technique is perfect. So this thing actually extends into the epiglottis and lifts it directly up. The Mac blade extends into the vallecula and lifts it, the epiglottis up indirectly. Indirectly lifts it. Return of the Mac. What you got?
So would the Miller be more suitable for those very difficult intubations?
Yes. Like Chunky Nick gives me a lot longer. I would call it a shooting alley. You know, it gives me a longer view of where I want to aim and shoot that tube at. So yeah, for big bull necks, this might be a good idea for that. So like, I like the Mac blade. That's my guy. I like a little curve in it. I like curves. So I start with a Mac 3. And again, I don't go back. If I don't get it with that first intubation, now it's time to change blades and blade sizes and figure out a new plan. So then I'll move to a Miller secondly. That way, if it is a more difficult or a chunkier neck or something, I have tried 2 different blades, 2 different sizes, blah, blah, blah. So the Mac curves into the vallecula and does what? Indirectly lifts the epiglottis out of the way. You will have to find what you like with your Paramedic scope. Blades range from size 0 and 1 and 2 for infants and kids. 3 and 4 are considered the adult sizes, with the average adult being around a 3 and the larger adult being on that 4 range. The average adult being a 3, them biggins, they get the 4. Pediatric patients, we're basing that on height and weight. It's really great on the Broslow. A lot of times the Broslow will give you actually what tube size and what blade you should try. Not that it's always going to be right and perfect, but it's a good place to start. And as far as adults, you see on there, it's written based on experience. Whose experience? Provider. So that means dealer's choice. Dealer's choice. So you find what you like. You know how you find that? You practice. Bring your butt in this lab, and we beat you down with it until you've got what you want. You find comfort. We're going to do it so much, so often, so soon. We're going to do it on mannequins, then different mannequins. Then I'm going to put the mannequins in different places. I might even tape one to the wall again, make you do it upside down. Might do it on the stairs, underneath the floor. All to facilitate all the difficult places you can intubate. Patient stuck in an elevator. I couldn't get in the elevator, but I could drag his head out. Gosh, I can't make the crap up, man.
Wow.
That's why I love this city. I do. I talk a lot of crap about it. I've had a good time here. I've had a good time. I couldn't get this stuff in South Georgia. There's no way. There's a guy in the elevator who's not breathing. He's now in cardiac. He's going to go into cardiac arrest soon, right? He's not breathing, and the elevator's like here, and we can open the doors, and you can pull his head out. So I'm up here on like a chair, trying to intubate the guy. And I get it. So I'm bagging him until we can get him out.
Yeah, I was about to say, if I would have his head get cut off.
Ooh, yeah. Well, I wouldn't about to put my hand in there. But his head was hanging out.
Push his head up there.
Yes. I love the city. You go get a job at G Unit, you can run some calls like that. Another thing I love was the architecture, the street art, the food. Man, it was just a good time. But my favorite part of working in Atlanta was Saturday nights at around 4 or 5 a.m. You done ran your butt off all night, and like a damn toddler, the city's been acting like a fool all night. But around 4 or 5 a.m., you done put that little baby to bed, and it's chill time for the next 3 or 4 hours. You might run a call here and there, like I woke up, my chest hurts and this, but you don't put the city to bed mostly. And that's when the city belongs to you. You're riding to your post. You can just kind of enjoy the scenery and stuff. It's very, very chill. This is my favorite.
My motorcycle again. And at 6 o'clock, somebody gets stabbed to death.
Good morning. Good morning from Atlanta. Stab. Anyway, here we are. McGill forceps, we have these. Their job is to do what? Under direct visualization, guide ET tips through glottic opening. You can use the McGill forceps for that. Also, you can use it to do what? Grab crap out of the trachea. Orotracheal intubation by direct laryngoscopy. Now, what does it mean for scopy? What does that mean? To look at. Scopy means just to look at. Hey, Martin, you're the expert. What's a colonoscopy mean?
Colon.
I'm gonna check your colon out. Okay. So, scopy means just to take a look at it. So when I take laryngoscope and I directly view the larynx, I'm doing a laryngoscopy, right? That's what you're doing here. ET tube is inserted through the mouth into the trachea while you're visualizing it, going through the glottic opening. Questions? Cool. I like it. You know what?